In today's episode, we're going to talk about the importance of supervision. Now, I learned about this a very long time when I was a graduate of Columbia and Psychoanalytic Institute in child psychiatry, and I was thrown out into the world, and I realized that I knew very little. It was one thing to have supervision and wonderful mentors, but I knew that it was very important in terms of lifelong learning that I would continue the education process, and to tell you the truth, I've never stopped. I was very used to meeting with my fellow residents at least once a week together, and we would discuss all of the things we learned from the various supervisors, each one, of course, who had a different point of view. I learned then the importance of sharing our ideas, and I never stopped. Later, when I became a director of training, I realized the importance of supervision. Everyone, of course, has supervisors and mentors, but what's important is it's the bare bones of it. When they graduate, they really don't know what they're doing, and they do need consultation with so many of their colleagues and friends. Therefore, many years ago, I set up a plan of graduates of my own, child and adolescent fellows and residents, and sometimes child psychologists. We would meet every other week in my home on the dining room table and discuss our cases. Now that is actually what we're going to demonstrate today. Each one of the graduates had a very interesting experience, unique to him or her. There was no pressure, no grades, no stress. It was just a way of all of us getting together and sharing our experiences, which could not be the same for each person. I call this peer supervision, and we've done that for many, many years, with the great benefit of having many of my former students achieve fame in many, many areas, but still they come to share their experience and learn from others. And I can tell you, I have learned a great deal from my peers. Today we are going to present the first of several case presentations by the members of the group. And I think it's very important to know that these children have atypical development. Now, what that means, that it's not, quote, the normal child, the typical developing child that we saw before in the other two episodes, one of a 5-year-old and one of 11, but of children who have certain pathology. It's very important to note that there is no such case of an actual patient being presented. It's a compilation of several cases that would be of great interest to all of the mental health professionals, since they see so many typical cases like this. Without further ado, let's listen to Scott's presentation.
I have a 7-year-old that wanted to present. So her name is Maddie. She's 7 years old, and she was referred to me through a colleague who sees the mother for psychotherapy. The parents are divorced. They minimally communicate with each other. She's very close with her nanny and her oldest brother, who's about 12 years older than she is. Parents generally don't get along and haven't ever. In terms of her past history, she was a planned pregnancy. She had a C-section. Her talk was delayed by maybe 6 months to a year. She received speech therapy. She went to nursery school in pre-K. As she got more and more into school, she found school more challenging. She had a lot of stomach aches. She was quite avoidant. She's very attached to the home where the mother lives, and that's where she lived her entire life. She's not as specific about being separated from her mother, her father, or the nanny, but she's very attached to the home. She's worried about starting kindergarten this year. Her pre-K, which was very minimal, was mostly remote. She does have some friends, but she's very demanding at times. There's a history of bedwetting, biting her siblings. She has a limited food intake, and generally in groups, she's selectively mute. When I asked what the parents would want to focus on, they would like her to sleep in her own room. They would like her to have less stomach aches, and they would like her to be more open about going to school. When I asked her what she likes about herself, she said she likes her hair color, she likes her toys, and she likes ice cream. She's very engaged. She's very excited to talk. She wanted to show me her room virtually. She drew a family photo for me. She drew black stick figures to represent her parents and her brothers. She left herself out, but she included the dog, and she was more detailed in drawing the sky blue and the grass green. But she added herself into the photo when I reminded her that she forgot herself. She has a medical history of asthma. She doesn't have any allergies. She's never been in therapy before or seen by a child psychiatrist or anybody, any mental health professional. She has the speech therapy that she had a few years back. Her family history is significant for substance abuse, alcoholism, bipolar disorder, learning disabilities, and ADHD, as well as anxiety. So
wait a minute. Who in the family had all of those things? Did one person have them all, or six people have each one?
Good question. Her brother's diagnosed and treated for ADHD. Her grandfather on her father's side is diagnosed with alcoholism. A distant cousin of the father's is diagnosed with substance abuse and bipolar disorder. A maternal aunt, as well as her children, so the cousins of the patient, have been diagnosed and treated for anxiety, and that's on the mother's side.
It's very important that you got a really good genetic history, because I'm hearing everything except one thing, the delayed speech. Is there a learning disability of language? No, I don't mean speech, but I mean actually language.
There was no follow-up. They did some type of interventions, and when she made some sort of milestones, they just sort of stopped. But they don't really have any specific formal paperwork that they gave me. Mm-hmm. And there's never been a neuropsych testing. The teachers haven't complained about anything regarding her speech, other than at times she's shy in groups and selectively mute.
So what are you doing with her? What's your goal?
My goal is to get to know her. We're doing a lot of play therapy. She seems quite comfortable in meeting once a week. Her parents are trying to get her more familiar with the idea of going to kindergarten this year. I've only been working with her for less than a month. So we did talk to the school and see if she could visit the new school before the first day of school. And the nanny and the parents are walking her by the school to get her more familiar with the idea that this is like a new home for her. Again, she's very attached to the home that she's in.
Well, I do have some suggestions. First of all, the selective mute is obvious when she couldn't make herself understood, and people said, what, and I explain it and whatever, when she was very little and had the speech problem. So she's selectively mute. She's comfortable in her house, in that surrounding, but not in the rest of the world. So it's very wise for the teachers to come to the house to get her, or the parents to pass the school and to get comfortable. But this is the kind of girl that I think is very important for the school to know. This guidance counselor or the psychologist or whoever it is, some parents are too afraid to mention this, but it's very important in her case, because there can be wonderful treatment by a teacher therapist, a teacher who would put her with another child or two or three together and make sure that they have a project together, or they do finger paint or whatever it is, but that there's a small group within the classroom. That doesn't mean they have to be taken out, but where that teacher could be an assistant teacher, could be somebody else, knows that everybody has to talk when they say, pass the milk, please, or give me the cookie, or whatever it is, that they would be working on that, even though it's sort of done with mirrors. But a good teacher therapist in a preschool, like the kind of thing they teach at Bank Street, it wouldn't even need a psychiatrist coming in, or observation or test and all that. That would be the school. And if the school knows that you're interested in this little girl and you think she's a wonderful girl and very bright and very lovely, but shy, and it had the selective mute problem, that would be one way the school can handle that, and she'd be comfortable. The other thing is that you can play out with a little dollhouse. One is the home and one is the school. And you can do some beautiful play therapy with her about going to school. And there's a girl who talks a lot, and there's one who doesn't talk at all. And there's a teacher who's nice and one who's mean. Everything is black and white with this age anyway. And she would have fun playing out, and you would learn an enormous amount about what's going on with her. I would do the play therapy with her. Once a week is fine, and she'll remember, but the imaginative play and acting out some of her fears, because she's very frightened that people didn't understand her or didn't like her or made a face at her or whatever it was. So that's why the school environment with a good teacher therapist can be enormously helpful here. The other thing is that I would wait maybe 6 months or maybe a year, but I would get neuropsych testing because I think there is more there. There may be language problem. We don't know. It depends on reading and if she likes it and is able to. So you'll know a little more academically. There are some tests that she could have from school, but I would keep in mind a good language pathologist to see, because you want her to be, by the time she's in second grade, very fluent. And a lot of people won't even test them until it's 2 years below the mean. So you'll know very much in the next year or so. But it's a lovely case. She's safe in her home. It's like a little bear in a cave, doesn't want to go out into the world. But this is helping her a lot, and that play will help her a lot.
Scott, do you think the mom would be open to forming friendships with the other moms in the class so that you could task the mom with being more involved with the school environment?
That's a great idea. The mom will do whatever is needed. You could tell she's quite anxious herself. So the idea of socializing, I'm not sure how easy it will be for her, but she definitely would do it. But I think that's a great idea to help connect. Even with her, I think the nanny is quite good at bridging. And I think the nanny could even be involved in that in a way. I think the nanny and the mom together could do this. The dad also, but the nanny could do a lot of that.
Yeah, because I think it's through the play dates and through the relationships with the other moms that they can get an idea of what the hierarchy looks like within the classroom, right? And once they see the hierarchy in the classroom, they can see like, well, where does the patient fit in this social hierarchy in that little microcosm?
That's such a great idea.
Yes.
I really like that.
Really, it is excellent.
And it makes the mom do something. So you're not doing everything.
Yeah, right. That's true.
This kid seems extremely anxious to me. Maybe we should consider a behavioral approach. I actually kept thinking TFP, which is very interesting. This is a kid that instead of seeing 3 times for like play therapy, I would actually collaborate with a CBT expert or do CBT yourself. I know Clarice usually prefers that when we do it all ourselves, right? So I would definitely do some CBT with her because there's anxiety everywhere.
That's a great idea. I like that.
You know, Angel's idea for this child is very important because if she goes to a really good center, what they do is that they have a group for the children, they have individual group, and they have parent education. And they also have some family therapy. I don't mean everybody gets everything all at once, but to be able to have that modality and a behavioral system is very good, you know. And sometimes there's a mother who is so ill at ease with the other mothers that the child senses it. Mother doesn't look right, she doesn't dress right, she doesn't raise her eyes with the other mothers, she doesn't want to meet with them. But sometimes you have to know, is the mother capable of even going out and meeting the other mothers? Sometimes not. But that is something that for a mother who would be that anxious, wouldn't have some of those problems, that's a very, very good idea. You've just started, you've only seen her for a month and it's already going well.
Yeah, I like all the ideas of putting them together. And I think some of the behavioral work that I maybe not thought of, but just did, was really with the parents of trying to get them to go by the school. And if they're comfortable going by the school, then Maddie's going to feel comfortable with it too. Because again, I thought it was unique that the parents both said She's very attached to the house, not necessarily the nanny. Usually you think of like an attachment with the mother and doesn't want to leave the mother, but she's really attached to the house. And I think with Betty's point of the idea of going, the mom being at ease to go and socialize, and maybe the girl will be more comfortable, I think is so true. And if it doesn't work so well, I think that doing something more concretely behaviorally oriented with her, she's smart enough, she's interested in this. And if we have such a good connection, I think she would do these things.
I had one more question. I'm just thinking of her history that you presented. I'm thinking of when you asked her to draw a family, and she didn't put herself in the picture until you reminded her, right? And then just thinking of her being attached to the house. These parents seem to be quite disconnected, and the house is a stabilizing place for her. And how can you transfer that for the school? I guess those questions come to mind, kind of thoughts about her not placing herself in the picture. And then
yeah, I thought for her to forget herself could be just age dependent, that she's concrete, that she drew her family, which she's not necessarily a part of. It's the other people. She can't see herself, but there's maybe more something psychological about her forgetting herself too. Thank you, everybody. This is very helpful.
It's a very, very nice case. And we'll hear about it more in a few months, because there's a lot going on with this little girl. She's going to be fine. You'll see.
I think it's clear from this presentation that Scott learned a great deal from the group. They gave some wonderful suggestions, recommendations, and I think a valuable experience for all. Thanks for watching, everyone, and see you next time.